Incidence of HCM is highest in patients with breast cancer that has metastasized to bone and in patients with squamous cell lung cancer. And together, these two cancers account for more than 50% of the cases of HCM. In general, it's not easy to identify early HCM because the clinical manifestations are typically nonspecific and vague. And usually in a patient with cancer, it's attributed to the disease process or treatment side effects or existing comorbid conditions. The skeleton is the major storage site of calcium. Skeletal bone is not inert, and it's a dynamic organ that's acted upon by hormones to release calcium into the bloodstream. Cancer cells can subvert this finely regulated balance.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. And today we are joined by ONS member Marcel Kaplan, Breast Oncology Clinical Specialist, to discuss hypercalcemia of malignancy, which we'll call HCM from now on, and its current management and treatment strategies. Marcel wrote the chapter on HCM for ONS's book about oncologic emergencies and served as the book's editor, which we've linked in the episode notes. This episode is part of a series about oncologic emergencies. The previous episodes are also linked in the episode notes. You can also earn free NCPD contact hours by completing the evaluation we've linked in the episode notes. Thanks for joining me today, Marcel.
Oh, I'm pleased to share some highlights about HCM with your audience.
So, oncologic emergencies are one of those foundational things that oncology nurses absolutely need to know. And there are several of them. So, it's so important for our listeners that we have today to really understand and really take a listen to all of the podcasts that we have about these different emergencies that they may encounter with patients that they are caring for. So to start us off, Marcel, can you give us some background on HCM and what it is and how it presents in our patients?
So most patients and probably many nurses have never heard of HCM, but it is the most common life-threatening metabolic complication of malignancy. It occurs in about 30% of patients with cancer at some point during the course of their disease. And when it does appear, it typically represents advanced or progressive cancer and portends a brief life expectancy. So the underlying pathology that causes HCM is quite complex. So I'm just going to briefly say that it really helps to understand that the serum calcium levels in the body are maintained within a very narrow and constant range through finely tuned interactions between skeletal bone, the gut, and the kidneys. It usually works very well, except when certain cancers are present and that can interfere with the balance between bone breakdown and bone formation. And how they do that is that cells of certain cancers are able to secrete substances that cause pathologic destruction of bone. And in fact, there's so much calcium released from bone into circulation that it overwhelms the abilities of the kidneys to excrete the excess calcium and then the concentration of serum calcium in the blood increases. Another way that hypercalcemia can occur, there are certain cancers, such as the lymphomas, that are able to abnormally synthesize vitamin D. And that means that more calcium is absorbed from the gut, and that leads to elevated serum calcium levels.
Well, thank you. What an interesting side effect or actually, issue that patients may have. Are there certain patient populations that are at higher risk for developing HCM depending on their cancer or tumor diagnosis?
Yes, the incidence of HCM is highest in patients with breast cancer that has metastasized to bone and in patients with squamous cell lung cancer. And together, these two cancers account for more than 50% of the cases of HCM. The third most common cancer associated with HCM is multiple myeloma, which is a primary cancer of the skeletal system. And there are other solid tumors also associated with increased risk, and they are squamous cell carcinomas of the kidney, the head and neck, and certain GYN malignancies. And an interesting point is it's not necessarily associated with bone metastases, because patients with prostate cancer, which is frequently associated with metastases of bone, rarely develop HCM.
That is very interesting because, like you said, you would think that when the bones are affected, that would be something that would cause patients to have a higher risk of. What etiologies can lead to HCM?
So basically, what happens, why HCM develops, is because an imbalance develops between bone formation and bone destruction caused by the release of factors by the cancer cells. And ultimately, this excessive calcium in circulation impairs renal function. So, in general, it's not easy to identify early HCM because the clinical manifestations are typically nonspecific and vague. And usually, in a patient with cancer, it's attributed to the disease process or treatment side effects or existing comorbid conditions. So I'll give you some examples. Like in the GI system, the early symptoms are anorexia, nausea, vomiting, constipation. Also, muscle weakness and fatigue occur. So that's very nonspecific. But however, with HCM, the organs that are most profoundly affected is the central nervous system, the brain, and the kidneys. So what happens is you have mental status changes. And these changes in a patient with an existing history of cancer have to be evaluated. And these changes would be restlessness, irritability, confusion, let's say personality and cognitive changes. And in a person with an existing history of cancer, that always has to be assessed. Now, in the kidneys, the presence of HCM makes the kidneys unable to concentrate urine. So the patient puts out large volumes of dilute urine. Also, they get up at night, they have nocturia, and they develop polydipsia, which is excessive thirst stimulated by loss of large volumes of fluid. And these large losses of fluid cause severe dehydration, and that further impairs renal function, which further contributes to hypercalcemia, and a vicious cycle develops.
So many of those symptoms that you just mentioned are symptoms of a lot of other issues that patients, especially oncology patients, have. So I'm sure that, when you have a complicated patient case and not only are their treatments complicated, but the side effects from those treatments, as well as, something like HCM can overlap. So for nurses who are, listening and thinking about patients that they're caring for, what kinds of things might the oncology nurse identify early to help to recognize that a patient is having an issue with HCM?
Recognizing early HCM, I would say, takes astute nursing skills. And number one, I would say nurses have to be aware of which patients, with what types of cancer are at increased risk. So they have to know the cancer history of the patient and whether there's bone involvement. And they have to have an awareness of the early signs and symptoms of HCM, which, as we describe, are typically nonspecific. The key to diagnose a patient is to do a laboratory test of the serum calcium. Now, in general, calcium containing foods do not have to be avoided except in patients whose hypercalcemia develops due to vitamin D synthesis, abnormal synthesis, in the lymphomas. And those patients have to be advised to avoid intake of calcium rich foods such as dairy products and fortified cereals. Also, the oncology nurse can try to encourage the patient to increase their fluid intake and their weight bearing activities. I mean, as a general good practice. So it's difficult.
It sure is. Like I said, it's just thinking about, as over the podcast that we've had and talking about new treatments and even just a diagnosis, like you said, can cause some of these symptoms to occur. So trying to figure out what exactly is happening and understanding all of these different possibilities is such an important thing for an oncology nurse to know. So that now that we've talked about the signs and symptoms, what would the diagnostic process for a patient with suspected HCM be?
Well, diagnosis first, you need to do a careful patient history and physical exam, and because you want to differentiate between malignant causes of hypercalcemia and benign causes, because there are benign causes if somebody has primary parathyroidism, let's say. And the type and severity of symptoms have to be assessed, and the presence of dehydration, very important. Patients with a known history of cancer, you talk about what kind of cancer and how it was treated and when. But hypercalcemia may also be the first indication of an unsuspected malignancy. So, in that case, you have to ask the patient about existing risk factors for cancer with a special focus, let's say, on cancers associated with increased incidence of hypercal, such as, risk factors for lung cancer, smoking, or breast cancer, family history. And the most critical piece, of course, is to review laboratory results for serum calcium. Now, serum calcium, it's sort of a roundabout way to get an estimated level of serum calcium concentration because calcium ions circulate in the blood in two forms: free ions or ions that are bound to albumin. And the ions bound to albumin are inactive, and the free ones are physiologically active. Now, when serum albumin levels are low, such as happens a lot of times with cancer patients, that means more calcium is circulating in the free, unbound, active state. Typically, total serum calcium is measured, doesn't distinguish, so there is like a simple mathematical formula that's used to arrive at what's called the estimated corrected serum calcium concentration. And based on the results of this correction algorithm, HCM can be graded into three categories: mild, moderate, and severe. And there's another wrinkle: symptom severity may not even correlate with the increase in the calcium, but in how rapidly the calcium increases and the age and performance status of the patient. Also, renal function tests are mandatory, and in patients with lymphoma, vitamin D levels would be assessed. So that's just a beginning.
It's so important for nurses to understand all of this, and it's so complex, and I think that's why, as I mentioned at the beginning, these are foundational things for oncology nurses to understand and watch for, because you have just given so many different examples of how it could be a patient that has HCM, or it could be an underlying diagnosis that has not, been diagnosed yet, some other type of cancer. So now that we've talked a little bit about the signs and symptoms and the how that diagnostic process works, let's talk a little bit about treatment. What are some interventions or drugs that are used to manage HCM? And are there any special nursing considerations that might go along with this?
Treatment is complicated, but the most effective method to control HCM is to control the underlying malignancy that's precipitating the HCM, to ablate it, with cytotoxic treatments. But that will take time. And this patient, we're talking about patients with severe hypercalcemia, are admitted to the hospital because the treatment is very intense. So they need to have the elevated serum calcium rapidly lowered and the dehydration reversed and their symptoms relieved, because I just mentioned early symptoms. As it progresses, the symptoms become very distressing and could be fatal. So the cornerstone of initial anti-hypercalcemic therapy is to restore normal fluid volume and correct the dehydration by vigorously rehydrating the patient with IV normal saline. And vigorous is like 200 to 300 milliliters per hour until the patient achieves a urine output about 75 mils per hour. I mean, if they can tolerate this kind of aggressive hydration. So, and the nurse, of course, would monitor the fluid status, the INO, and the lab results of calcium and other serum electrolytes, which could also be flushed out in this treatment. But this kind of normal saline rehydration cannot be used long term. So the ongoing treatment that's the mainstay for long-term management of HCM is to use agents that inhibit bone breakdown and prevent the release of all this excess calcium into circulation. So there's two types of drugs that are used for this. The first type are bisphosphonates, which have a composition similar to bone, and they are associated with renal toxicity. And here you have patients who already have renal dysfunction. So before every infusion, renal function has to be monitored and the drug either decreased or held. And the second type of drug is denosumab, which is a monoclonal antibody that's approved by the FDA to treat HCM that hasn't responded to bisphosphonates therapies. So you have fluid volume correction, dehydration improvement, inhibit bone breakdown. There also may be additional agents used to force increased diuresis, such as furosemide, or other agents to inhibit bone loss, such as calcitonin. And for patients who can tolerate rehydration with saline, dialysis may be an option. The treatments are very involved, and the nursing care is very involved.
Okay. Well, you've talked about we're talking about hypercalcemia, and we know that, there are medications that can cause or worsen hypercalcemia. So, what are some of those medications that oncology nurses should watch for that the patient may be on prior to, or, that get added on afterwards for a patient who might be at higher risk for HCM?
A list of medications and supplements should be reviewed with attention to certain drugs that can increase serum calcium levels, and those include thiazide diuretics and excessive intakes of vitamins A and D, use of calcium containing antacids, theophylline, lithium, and there's other drugs, and all of these drugs should be discontinued as appropriate, if possible, because they do contribute to increased serum calcium.
Thank you. That's really an important thing for our listeners to be aware of. So, the occurrence of HCM can lead to some difficult patient and provider decisions about treatment. Can you explain what is involved at both levels?
Typically, HCM appears in patients who have progressive or advanced cancer and indicates basically a terminal phase in their life, very short remaining life expectancy. So a decision might make sense not to start these aggressive anti-hypercalcemic treatments and to send the patient home with the hospice care that will include interventions to palliate the very distressing symptoms of hypercalcemia, provide comfort care, and the decision would depend on taking into account the risks and benefits of the aggressive therapies, the patient's performance status and quality of life, their prognosis for survival, and their end of life goals. Now, severe hypercalcemia is associated with it depresses the cerebral function and leads to coma. So, someone that might be expected to lapse into a coma, that might be a more gentle way for them to go with no sense of pain. But certainly in patients where it appears where they don't have a pre-existing diagnosis of malignancy and it's the first sign of malignancy, no, that has to be aggressively treated to control the precipitating malignancy and to reverse the serum calcium levels.
Marcel, that was great information for us and for the nurses that are listening, just to kind of understand why, HCM could happen at a difficult time during a patient's cancer journey, and how important it is to understand when and how that symptom might come up. So, in thinking about our listeners, what are some important nursing considerations for those nurses providing care for patients with HCM, and education that they could, provide to these patients?
Nursing care of patients with HCM is complex and involves numerous tasks, including initially providing prevention measures, which probably will not really do much for somebody whose cancer is precipitating that. But prevention, including, is encouraging, increased fluid intake, about 3 liters a day, weight bearing, and also being able to assess the appearance of early symptoms and report. Early detection is important to keep HCM from becoming a life threatening oncologic emergency. And nurses would monitor laboratory test results for fluid and electrolyte balance and assess muscle strength, institute safety measures and comfort and pain relief measures, evaluate the typical nursing process, evaluate treatment effectiveness and side effects, and provide education and emotional support to patients and caregivers. And I would say that the education is an important piece, and certainly the caregivers should be included because the patients may have mental status changes. So when the patient's at home, let's say, they would again reinforce adequate hydration and safe weight bearing activities, teach them how to recognize the non-specific symptoms associated with HCM, the anorexia, the nausea, lethargy, excessive thirst, and the importance of reporting them to the healthcare team. And let's say progressive changes in mental status. Also important to recognize and report conditions that contribute to fluid loss that would exacerbate dehydration and increase renal dysfunction, and that would, let's say, diarrhea, vomiting, fever, and teach the patients and caregivers to avoid the certain drugs that increase calcium, serum calcium levels. We said the thiazide diuretics and vitamin supplements, and teach them how to protect the patient against falls and the need for close observation of patients who are confused or reckless. So there's a lot. It's intensive teaching.
Now, are there any gero-oncology considerations with HCM?
Yes, elderly people can develop HCM due to a history of cancer or an unsuspected malignancy, but they may also be at risk for hypercalcemia from causes other than from cancer. And also, patients with a history of cancer can develop increased calcium from non malignant causes and what they are. So, typically, the incidence of primary hyperparathyroidism. It's quite common in the general population and increases as people age, the potential. Or an elderly person might become immobilized or use thiazide diuretics. And people with mild hypercalcemia, which is typically from these benign causes, are typically asymptomatic and may be diagnosed only incidentally from the results of routine blood tests. But further evaluation should always be considered. And it could be, as we said, the presentation of an unsuspected malignancy.
Marcel, this has been very insightful, and I think that it is going to be very helpful to all of our listeners, especially, as a very good reminder for us oncology nurses who are experienced and maybe haven't seen HCM for a while. And then also for our new to oncology nurses that are listening and trying to increase their understanding of the whole cancer experience for our patients. So it has been wonderful discussing this with you. And I just have some questions that I would like to end our podcast with that I ask at the end of every podcast. And I'm going to ask those in a real quick fire manner to you now. And the first one is, what are common misconceptions about HCM?
Well, my answer in general would be that a lot of people have never heard of it, but a common misconception could be that its occurrence is a one time event. But if it's a progressive cancer, even if the initial bout of HCM is corrected, it can recur. It's not necessarily a single event.
Okay. The next question is, what's something about HCM that's not often discussed, but you wish people knew more about?
Yeah, well, as I described, the option of either not initiating aggressive therapies or discontinuing aggressive therapies is something that, is hard to present, I think. For a lot, people, when they get diagnosed with a condition, they want to do everything they can to treat it and make it go away. But in certain cases, The treatments most likely will be futile. So in this situation, nurses should provide emotional support and support the patient caregivers, decision making and coping, and possibly, if necessary, provide referrals for counseling.
Okay. What additional training or education do nurses need to know to manage patients with HCM?
Well, due to constraints of time, I only touched on the highlights of HCM. The pathologic mechanisms underlying this are so complex that it's hard to present in a forum like ours. But I think nurses should be aware that skeletal bone, the skeleton is the major storage site of calcium. Skeletal bone is not inert, and it's a dynamic organ that's acted upon by hormones to release calcium into the bloodstream, and that cancer cells can subvert this finely regulated balance. Also, I think it'd be useful to understand the fundamental role that calcium plays in our bodies, because then the nurses could sort of tie it to the symptoms. So it's involved in the formation and maintenance of bone and teeth, the contractility of all types of muscles, and the conduction of nerve impulses. Knowing that, I think, would be useful, just basic biology. Also, understanding why it's so necessary to measure total serum calcium levels in combination with albumin levels in the blood.
Okay. And then last, what are some additional resources for both patients and providers who want to learn more about HCM?
Well, as I said, in this brief time, we can only touch on highlights. So I would personally highly recommend the chapter that appears in the ONS book, Understanding and Managing Oncologic Emergencies, a resource for nurses. I wrote the chapter many times, and it includes figures and tables that help to illustrate the content, and I think makes it easier to digest.
Well, Marcel, again, I would just like to thank you for joining me today. It has definitely been insightful and a really good reminder of one of the oncologic emergencies that our patients can experience during their treatment. Do you have any final comments for us today?
Yeah, well, I just hope that our discussion has raised the awareness about the potential for HCM developing in patients with cancer, and help oncology nurses recognize and report it early so appropriate treatment can be instituted before it becomes a life-threatening oncologic emergency.
Thank you for joining me today. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.